Welcome to the deep dive. Today we're really getting into something fundamental for geriatric care. Chapter 6, all about maintaining fluid balance and meeting nutritional needs. Our mission here is simple. Break down what you need to know. We'll look at how aging changes nutritional needs, why older adults are so vulnerable, and crucially, what nurses actually do about it.
It's so important because, honestly, nutrition and hydration, they're central. They impact everything from managing chronic diseases to just basic health maintenance.
Yeah.
We have to look at the physiology, sure, but also the psychosocial factors, the context.
Exactly. And I think the core idea right off the bat is that nutritional needs change. Understanding those caloric shifts, but also the nutrient requirements is, well, it's key. #TagGuy, the core components of nutrition and aging.
Let's start with the basics, the energy equation. Generally, as people age, their caloric needs, they tend to go down.
Right, that makes sense. Less muscle mass, maybe more adipose tissue.
Precisely. And a lower basal metabolic rate, the BMR. So the body's just not burning energy at the same rate at rest. And if an older adult is inactive, they really need to cut back on calories.
But here's the catch, isn't it? The source mentions a minimum, like 1,200 calories a day, is needed just to get the basic nutrients in. And we use BMI, body mass index, as a good measure for body fat, right?
That's right. BMI is still a reliable indicator, and you hit the nail on the head. Even with fewer calories needed overall, the requirement for all those essential nutrients, vitamins, minerals, protein, it stays pretty constant.
Because you can't just eat less of everything.
No, absolutely not. It means you have to be really selective. Choose nutrient-dense foods. Foods that pack a lot of nutritional punch for fewer calories. That's the mandate.
Okay, so nutrient density is the goal. Let's break down the macronutrients then. Starting with carbohydrates, I see the text distinguishes between simple and complex.
Yeah, that's a key difference. Simple carbs, like sugars, they hit your bloodstream really fast. You get that quick energy spike, then often a crash.
Not ideal.
Not usually, no. Complex carbohydrates, think vegetables, whole grains, fruits. They're digested more slowly. They provide sustained energy plus bulk and fiber.
And that fiber does more than just help with regularity, right?
Oh, much more. Soluble fiber especially helps with elimination, preventing issues like diverticulitis, but it also plays a role in lowering cholesterol. The recommendation is still about 45% to 65% of calories from carbs, but really emphasizing those complex ones.
Makes sense. Now, protein. Crucial for keeping muscle, and the text really stresses its role in healing.
Absolutely critical. Protein needs generally don't decrease with age, and sometimes they might even need to increase slightly.
Increase. Why is that?
To counteract that natural loss of lean muscle tissue, sarcopenia it's called. Plus, if someone's recovering from surgery or has a pressure injury, protein is absolutely essential for tissue repair.
So we need to know about complete versus complementary proteins.
Right. Complete proteins have all the essential amino acids, mostly animal sources like meat, eggs, dairy. Complementary proteins are when you combine different plant sources like beans and rice or legumes and grains to get that full amino acid profile.
Which is important for people maybe on a budget or who have trouble chewing meat. And I saw some practical tips in the source, like in box 6.1.
Yeah, simple things. Adding extra egg whites to scrambled eggs, putting cheese on vegetables, mixing legumes into soups or stews. Easy ways to bump up protein without a total diet overhaul.
Good tips. Okay, let's move to fats. The recommendation is around 20% to 35% of intake. They add flavor, help you feel full.
And they're vital for absorbing those fat-soluble vitamins, A, D, E, and K. You can't absorb them without fat.
But with fats, we always hear about the good and bad types, the lipoproteins.
Exactly. The text breaks it down. LDL, low-density lipoprotein, is often called the bad cholesterol because it carries cholesterol to the tissues and is linked to vessel disease.
And HDL.
HDL, high-density lipoprotein, is the good one. It actually helps protect vessels by carrying cholesterol away from the arteries back to the liver.
The source also mentions VLDL.
Yes, very low-density lipoprotein. That one's mainly linked to triglycerides. High triglycerides are another risk factor for heart disease, pretty common in older adults, sometimes due to diet or metabolic issues. So understanding all three gives a clearer picture of cardiovascular risk.
Okay, so that covers the big three macronutrients. What about the micronutrients, vitamins and minerals?
Right, the vitamins are split into fat-soluble A, D, E, K, and water-soluble, which are the B-complex vitamins and vitamin C.
And there's that theory about antioxidants.
Yes, the free radical theory of aging. The idea is that antioxidants like vitamins A, C, E, and beta-carotene might help neutralize free radicals, unstable molecules that can damage cells over time. so potentially slowing down some aging effects, though it's complex.
The text highlights a couple of vitamin deficiencies as being particularly risky in older adults.
Definitely. Vitamin D is a huge one. Older skin just doesn't synthesize vitamin D from sunlight as efficiently, and often older adults get less sun exposure anyway.
And the consequences are serious.
Very. It's linked to poor calcium absorption, leading to osteoporosis, but also muscle weakness, depression, and a significantly increased risk of falls.
Wow. And the other big one mentioned was B12.
Yes, vitamin B12. This is often an absorption problem. As we age, the stomach produces less acid and pepsin, which are needed to separate B12 from the protein it's bound to in food so it can be absorbed.
Leading to pernicious anemia.
That's the classic outcome, yes. But B12 deficiency can also cause significant neurological problems like tingling, numbness, balance issues, and even memory problems or confusion that can sometimes be mistaken for dementia.
That's scary. Okay, minerals. Calcium is the obvious one for bone.
Essential for bones, yes, but also nerve and muscle function. And as people age, especially if they're less mobile, bone loss accelerates, leading to osteoporosis. Which brings us back to vitamin D again. You need D to absorb calcium properly.
It's all connected. Let's touch on anemia again. You mentioned pernicious anemia with B12, but there's also iron deficiency anemia.
Right. Iron deficiency is often due to inadequate intake. Maybe meat is too expensive or hard to chew. Pernicious anemia is that B12 absorption issue due to lack of intrinsic factor. The key thing is the symptoms: fatigue, shortness of breath, pallor, headache can be really vague.
Easily dismissed as just getting older.
Exactly. So you can't dismiss it. You need to investigate, usually with lab tests like hemoglobin and hematocrit.
The text also briefly mentions zinc.
Yeah, zinc is important for wound healing, taste, and smell acuity, which impacts appetite and immune function. And minerals like sodium, potassium, phosphorus. Imbalances there are often related to medications like diuretics causing low potassium or underlying diseases.
One last thing in this section, functional foods. What are those exactly?
These are foods that go beyond just basic nutrition. They have documented health benefits. Think soy products, helping lower LDL cholesterol, or certain mushrooms boosting the immune system. Green tea. It's about using food proactively for health. Okay, now we need to face a really tough reality. Malnutrition in older adults. It's not just about not eating enough. It's any imbalance, insufficient, excessive, or problems with absorption.
And the statistics mentioned are, well, they're alarming.
They really are. Something like 10% to over 26% of older adults living in the community are at risk. But get this, in hospitals or long-term care facilities, that number jumps dramatically, maybe 30% to 50%.
50%, that's a crisis. Is it individual failure or is the system failing them?
I think it's often a mix, but those high numbers point to systemic issues, for sure. And part of the problem is that malnutrition can be subtle. The symptoms, losing weight without trying, feeling tired or lightheaded, they can mimic so many other things.
And unintentional weight loss is a key sign of frailty syndrome, isn't it?
Absolutely. Frailty syndrome is a major red flag. That unintentional weight loss is one of the core criteria, and it predicts decline, falls, hospitalization, poor outcomes all around.
So why does this happen so often? The source breaks down the risk factors into different categories. Let's start with the physiologic ones.
Yeah, aging itself presents challenges. Chronic health problems are a big one. Arthritis might make opening a jar impossible. Heart failure leaves someone too tired to shop or cook.
Sensory changes too.
Huge impact. If vision is poor, reading food labels or cooking instructions is hard. Changes in taste and smell can make food unappealing, or worse, someone might not realize food is spoiled.
And dental issues.
Oh, definitely. Poorly fitting dentures make chewing painful, especially things like meat or fresh vegetables. Dry mouth, often a side effect of medications, makes swallowing difficult. Decreased digestive enzymes can lead to indigestion. It's a whole cascade.
Then you add economic factors on top of that.
Right. Nutrient-dense foods, fresh produce, lean meats, they often cost more. If someone's on a fixed income, it's tough. And just getting food can be hard. Maybe they don't drive or the local grocery store closed. Lack of transportation is a real barrier.
And the social side. Eating isn't just about fuel.
Not at all. Depression, loneliness, grief, they all suppress appetite. Think about it. Cooking and eating a meal alone just isn't as enjoyable for most people. Motivation drops.
That's where things like Meals on Wheels or senior centers with meal programs come in, right? They tackle both nutrition and isolation.
Exactly. They're vital lifelines. And we should also mention the institutional factors contributing to those high rates in facilities. Sometimes it's repetitive menus, food that doesn't look appealing, a noisy dining room, or simply not enough staff help for residents who need assistance with feeding.
This seems to connect directly to the next major issue, fluid balance and dehydration.
It really does. Older adults just physiologically have less total body water to begin with, maybe 8 to 10% less than younger adults, especially inside the cells and tissues.
And other things compound that risk.
Two big ones. First, their sense of thirst often decreases. They literally don't feel thirsty even when their body needs fluid. Second, their kidneys become less efficient at concentrating urine, so they can lose more fluid that way.
So they need quite a bit of fluid. The text suggests 2,000 to 3,000 milliliters daily. What happens if they don't get it?
It can cause serious problems quickly. Dehydration can affect how medications are absorbed and metabolized. It's a major cause of constipation. It can worsen confusion, lead to falls, kidney problems. The list goes on.
The source mentioned categorizing people at risk.
Yeah, it's a useful way to think about it. You have those who can drink but don't, maybe due to forgetfulness or dementia. Then those who can drink but won't, often because they fear incontinence or having to get up to the bathroom frequently, especially at night.
And the third group?
Those who simply cannot drink independently. Maybe they have swallowing problems, severe weakness, or mobility issues that prevent them from reaching fluids.
And a critical safety point here, the link between dehydration, UTIs, and delirium.
Absolutely crucial for nurses to remember. Dehydration makes UTIs more likely. Both dehydration and UTIs are common, treatable causes of acute confusion or delirium in older adults. If you see sudden confusion, dehydration and infection should be right at the top of your assessment list.
Okay, let's shift to what nurses do. The nursing process starts with assessment gathering cues. We need both objective data.
Right. Things you can measure. BMI, tracking weight changes, especially rapid loss or gain, and of course, lab values.
Which labs are key here?
Hemoglobin and hematocrit for anemia. Serum albumin is a big one for assessing protein status and malnutrition risk, though it can be affected by other things too. And BUN, creatinine, and electrolytes, they give you a window into hydration status and kidney function.
And then there's the subjective side, what the patient tells you.
Exactly. Asking about their appetite, what they like and dislike, making sure to consider cultural or religious food practices, asking if they have nausea, pain, chewing problems, or that metallic taste some medications cause. It all paints a picture.
Once we have the assessment, we move to interventions. For nutrition, the source lists several practical actions, like monitoring weight, but weekly, not daily. Why weekly?
Daily weights can fluctuate a lot just based on fluid shifts. A weekly weight gives you a better trend line for actual nutritional changes, whether they're gaining or losing tissue mass.
Makes sense. What else? Oral hygiene?
Before meals, yes. It sounds simple, but if someone's mouth feels bad or is dry, food won't taste good and they won't want to eat. Also, working with the dietitian is key, making sure food looks appealing, served at the right temperature. Presentation matters.
How about strategies to actually increase intake?
Offer choices when possible, maybe something not on the standard menu. Limit drinks during the meal, especially low-calorie ones, so they don't fill up on fluids instead of food.
So save the fluids for between meals?
Often, yes. Or offer nutrient-dense fluids. Provide high-calorie, high-protein snacks between meals. And leverage the social aspect. Encourage family to bring in favorite foods, assuming they fit the diet. That could be a huge motivator.
Now, a really high-risk area, dysphagia, difficulty swallowing, the rates are staggering in long-term care.
They are 40% to 60%. It's common after stroke with Parkinson's, dementia, or just general frailty. And the biggest fear is aspiration food or fluid going into the lungs.
So interventions are critical. Collaboration first.
Absolutely. You need to involve speech-language pathologists and occupational therapists. They can assess the swallow, recommend diet modifications, and develop a specific plan.
Then positioning.
Crucial. Keep the person sitting upright, head level, or slightly flex forward, the chin tuck position. And they need to stay upright for at least 30 minutes after eating to reduce reflux risk.
What about the food itself?
Generally, you use small amounts. Often, thin liquids like water are the hardest to control, so thickened liquids are usually recommended. Foods with distinct textures and flavors can sometimes help stimulate awareness and the swallow reflex. Puree diets might be needed, but not always the first choice.
Any other safety measures for swallowing?
Yes. Provide verbal cues. Chew. Swallow. Sometimes gently stroking the neck can help trigger the swallow reflex. And because their cough or gag reflex might be weak, you absolutely must have suction equipment readily available just in case of choking or aspiration.
Okay, finally, what about patients who can't eat orally and need tube feedings? Nasogastric or gastric tubes?
Safety is paramount there too, mainly focused on preventing aspiration. Key things are Always verify the tube placement is correct before starting any feeding.
How is that usually done? X-ray initially, then often checking pH of aspirated contents or auscultation?
Exactly, and check for residual stomach contents before intermittent feedings. You measure what's left in the stomach, and typically you need to reinstill it to maintain fluid and electrolyte balance, unless the volume is very large per facility policy.
And positioning during and after feeding.
Keep the head of the bed elevated Fowler's or semi-Fowler's position during the feeding and for at least 30 to 45 minutes afterward. This uses gravity to help prevent reflux and aspiration. Always use clean technique for the equipment too. #tag outro. So when you pull it all together, what becomes clear is that caring for older adults effectively really hinges on recognizing these often subtle signs of nutritional and fluid imbalances. They can easily get lost amidst everything else that's going on with aging or chronic illness.
It really underscores the nurse's comprehensive role, doesn't it? You're looking at lab values, but also assessing their mood, their social situation, collaborating with therapists, and executing these really precise safety procedures like positioning for feeding. It's complex.
It is. And that complexity leads us to a final thought, something for you, the listener, to consider. We talked about those incredibly high rates of malnutrition in hospitalized older adults, up to 50%. So thinking beyond the individual nurse's actions at the bedside, what fundamental systemic changes might be needed within our acute care hospitals to make sure these vulnerable patients aren't actually becoming more malnourished while we're treating them for whatever else brought them in?
That's a powerful question. It shifts the focus from just individual care to the environment and systems impacting that care. Thank you for joining us on this deep dive into geriatric nutrition and fluid balance. We hope this helps you feel more confident in addressing these vital aspects of care.